This is a case of an elderly, frail gentleman who presented with symptomatic myeloma and was initially started on lenalidomide and dexamethasone with, I think, appropriate reductions in the lenalidomide dose based on renal function as well as overall performance status, and had about a 2-year duration of remission, had biochemical evidence of progression, and then the dose of lenalidomide was increased to 25 milligrams. That worked for about another year, and then had, again, clear progression with new bone lesions as well as, again, significant increase in the protein. I think the management of this case is really relatively straightforward. For a true, frail, transplant-ineligible patient, I think the standard does continue to remain the use of lenalidomide and dexamethasone. I think the doses that were used were reasonable doses. There is some question now about whether a triplet such as VRD, the addition of bortezomib to lenalidomide and dexamethasone, has become a standard for these patients based on the recent SWOG study. I think that is an important consideration, but given how frail this patient was, I'm not sure that I would have jumped in with a triplet combination at that time point. There are modifications that can be done to the VRD regimen, such as VRD Light, as is presented by the Mass General group. That also may be a consideration. But again, unless somebody doesn't have high-risk genetics, and he didn't appear to have high-risk genetics, I think the doublet of Lendex is a pretty reasonable therapy. So I think a major question that's going on in the field right now is about how to handle patients who have biochemical progression. This is something we're starting to see a lot more of, and we're paying a lot more attention to it because patients are on continuous therapy and are coming into the office much more frequently than they were, say, 10 or 20 years ago. And there is, again, a bit of a split. There are those in the myeloma working group who say biochemical progression is a short harbinger to clinical progression. You shouldn't wait. There are those of us in the working group, of which I'm a part of, that say the path to progression can be variable, and that patients can have long-term biochemical progression without any evidence of symptomatic relapse, and so you should watch it to get a sense for tempo of relapse. I will tell you, Ajay Nuka from our group actually looked at this very question from our own data set, and we had predicted that patients with high-risk genetics would biochemically progress very quickly, and so there wasn't a reason to start, whereas standard risk would biochemically progress relatively slowly, and those patients could be watched. And it turns out we were both wrong, that patients' progression has nothing to do with their genetics, although the tempo and way in which they initially presented may color that decision a little bit. I think that certainly the idea of continuing on therapy for patients that have only biochemical progression is a reasonable thing to do. We know that increasing the len dose from 10 or 15 up to 25 doesn't typically give you long-term disease control. In this case, it did, probably gave us about a year. But in general, I think we know that what we tend to do in these situations is just maintain the current dose and wait until we see either rapid progression or evidence of symptomatic progression. I think that the data around the use of increasing the dose of lenalidomide in the context of progression is relatively soft data. There was some unpublished data from the French that suggested that when patients progressed on len maintenance at 10 milligrams going up to 25 milligrams with the addition of dexamethasone may give you a short-term benefit. That data has never been published. There are other series that have reported similar outcomes where it may be a short-term response, but it's typically not a long-term response, and you don't know how much of that is an increase in the len dose versus adding the dex back in, which may do the same thing.